Gkmc 92 batch. I'm a nephrologist in Sydney. So, and we'll start with the introduction to nephrology. So, basically, nephrology is obviously one of the divisions of medicine. So you can divide nephrology into many domains, but I thought I'll just quickly talk about a few domains and on what we will be talking about, because where you will need a renal opinion or get an opinion from a nephrologist, these are the areas where you would probably want to get some opinion from a nephrologist. So first and most common for everybody is hypertension, high blood pressure, which is very common. Next is acute kidney injury. Now where your if you have to attribute most of our work and where you'll have make a critical difference in your knowledge of nephrology is in the management of acute kidney injury, because if you assess acute kidney injury and manage it very well, you can prevent chronic kidney disease, or in fact even save somebody's life. The third component is chronic kidney disease. This is at the stage where obviously people have progressed to chronic kidney disease, and you're looking at managing their kidney problems and all the other associated problems that come along with that. And obviously you have to transition them to dialysis or transplantation. And the other important thing which I have a personal interest in, which is probably very complicated, is electrolyte and acid-base imbalance. Can I ask you to put that light on? Electrolyte and acid-base imbalance. So then we'll touch a little bit on dialysis and renal immunology. Renal immunology is a very integral part of acute kidney injury, but I wouldn't delve too much into renal immunology because we'll discuss that within the context of the acute kidney injury. Okay. So let's go to hypertension. So hypertension, I just put one slide for hypertension because even though it's very common, what is more important for us is to understand what is essential hypertension and what is secondary hypertension, right? So essential hypertension is the most common cause of hypertension, where, you know, as you get older and older, the incidence of high blood pressure increases, and beyond the age of 55 or 60, a fairly significant proportion of the population does have hypertension. Now, you come into the picture as a nephrologist or as a physician when you are suspecting secondary hypertension. So when do you say it's secondary hypertension? When you see somebody who's quite young, like somebody who's in their 20s or in their 30s, who have new onset hypertension, and you really can't explain as to why this person's blood pressure has gone up, and that's fairly uncommon. So people who have young onset hypertension and people who have other endocrine problems, like there are associated problems, then you start thinking about secondary causes of hypertension. So why do we need to know secondary causes of hypertension? Because once you identify the cause of hypertension, you don't, instead of giving the medication for the rest of their lives, you can actually cure the hypertension. So the common things in terms of history that you would want to know is when was the high blood pressure picked up, and what was the reading in the first instance? Was it very high or was it just mildly elevated? And you also ask for endocrine questions. So most important endocrine questions I ask are weight gain, because if you look at the dot point number 3, you'll see that Cushing syndrome can manifest with high blood pressure as well. Cushing syndrome is an endocrine problem where you have lots of cortisol, and you gain weight, you develop stria, so it's a whole set of features. But hypertension is one of the features. And what I put in the bracket sub next to it is the investigation that you would want to do. So you may want to do the investigation, or you may get this help of your endocrine colleague to get this done. But as a physician trainee, it's good to know that this is what you would do. So most of the patients who come to me with secondary hypertension do have the one or two of the either point number 1 or point number 2. The first one is hyperaldosteronism. So where if you know the anatomy of the adrenal gland, it's got an it's adrenal cortex and the adrenal medulla, right? So the adrenal cortex has produces aldosterone from the outer layer. So the aldosterone is extremely important in maintaining your postural blood pressure and also in maintaining your blood pressure per se. Now, usually the aldosterone is the trigger for aldosterone is renin-angiotensin. That's the pathway. So sometimes what happens is you find that people do have very high aldosterone levels, which is not regulated. So previously it was believed that it is very uncommon, but now we know that up to 3% of patients, 3% is a big number, secondary hypertension, not primary and not essential hypertension, but secondary hypertension have high aldosterone. So what you do is you do an aldosterone to renin ratio, usually at 8 a.m. in the morning. And if you find that the ratio is high, then you start looking for any abnormality in the adrenal gland, look for any adenoma or any gland or any growth there. And a simple treatment would be just resection of that will actually cure the high blood pressure. The next important thing you have to look for is renal artery stenosis. What is renal artery stenosis? It's just narrowing of the blood supply to the kidneys. So it can happen in the context of two different contexts. One is in the setting of young females who may manifest with an abnormality of the vessel called as fibromuscular dysplasia. More commonly, it happens in older patients who have cholesterol deposition. Just like you have cholesterol deposition in the coronary arteries, they can have cholesterol deposition, and it can cause, it's known as atherosclerotic renal artery stenosis. Now, the investigations, again, I put in the bracket, are renal Doppler, which is an ultrasound Doppler study, and the CT renal angio, which tells you more about the anatomy, right? So the management in patients with fibromuscular dysplasia, young women, the management is intervention. Just like you do a coronary angioplasty, you can go in and the radiologist can do an angioplasty, or a vascular surgeon can do an angioplasty. In older patients with atherosclerotic renal artery stenosis, the evidence is strongly in favor of conservative management, so not much intervention. So that's probably the only difference you need to remember at this point in time. Now, endocrine abnormalities that you ask for are weight gain, weight loss, any thyroid function abnormalities, and all those things are quite important in the history. Now, the fourth point that I mentioned is pheochromocytoma. Now, everyone talks about pheochromocytoma. It is an... hello?
Yes, sir.
Sir, sorry, sir. Some participant has unmuted. That's why.
Okay.
We can continue.
Yeah. So pheochromocytoma is a tumor of the adrenal medulla, or rarely from the sympathetic chain. Extremely uncommon. I've never personally diagnosed anyone with that, but we always do tests, which is serum and urine catecholamines. Most importantly, we should never forget that genetics plays a big role. So if you have a patient who comes to your clinic and says they've been diagnosed with high blood pressure and they're in their 20s or 30s, and the first thing that I would ask them is, what age did their parents develop high blood pressure? If they say that their mother and father both develop high blood pressure in their 20s or 30s, then all your tests are going to come back as negative, because it's purely genetics. So they have had a set of bad genes which has been transmitted over to them, and they just become hypertensive because it runs in the family. So those are the relevant things that you will either see in the emergency or in the clinic. So sometimes you can have patients presenting with high blood pressure to the emergency. They'll manifest with a headache, or usually young patients may manifest with a nasal bleed or epistaxis. And you look at the blood pressure reading might be quite high. But most likely you'll have patients being referred to you in the clinics, and that's where you'll pick them up. So from the blood pressure perspective, I think if you know so much as a medical student, then I think that's probably more than enough, because blood pressure is a condition which is an overlap between nephrology and the cardiology, but usually it's the renal physicians are the ones who deal with this more often. Now, the chunk of the discussion I'll stick to is acute kidney injury, because acute kidney injury is extremely important for you, and you would probably, as a doctor working in the emergency accident and emergency, or if you're working in any other different rotation, like in general medicine or in surgery, or in obstetrics and gynecology or any other department, you'll find that acute kidney injury is a very common thing that happens to patients admitted in the hospital for a number of reasons, and also can be the reason for presentation to the hospital as well. So what is the definition of acute kidney injury? Acute kidney injury is defined as an abrupt decrease in kidney function. It's a broad clinical syndrome, and but the thing to remember is the two things that happen. One is you have a drop in kidney function manifested by a rise in creatinine and a drop in urine output. So when you say someone who's come to the hospital emergency and you do the labs for them, and you find that their creatinine, usually I think in India we use the ranges from 1.1 to 1.2 milligrams is the upper limit of normal. And if you find somebody's creatinine is 1.8 or 1.9 or even 2, then you think that, oh, there is a change, but you need to know whether the change is recent or whether that's been like that for a long time. So to broadly divide into three different divisions, it includes pre-renal, which is easy to manage, post-renal, which is easy to manage, but the renal cause of acute kidney injury is where you actually have to investigate and find out. So when you say pre-renal and post-renal, what do we mean by pre-renal and post-renal? Pre-renal is basically if somebody is dehydrated, they had an episode of diarrhea or vomiting, they've not been drinking well, or if they had cardiac failure because of which they are not perfusing their kidneys very well. So that is the cause of a pre-renal acute kidney injury. It's very easy to manage. And what you do, again, the history is very important. The history you take is what led to the presentation, and what is their, and the examination, what is their volume status? Are they looking dehydrated? Are they looking, or is their blood pressure low? So those are the things that you would want to investigate and find out. Now, post-renal basically is usually in the setting of obstruction. So this usually in the setting of men presenting with prostatic hypertrophy, or who have not paid heed to the symptoms, or who have had symptoms of obstruction, but suddenly they develop prostatitis or an infection and they go into obstruction. So it is basically an obstruction of the bladder, and the kidneys have difficulty in functioning. But one thing you should remember is we always think obstructive kidney disease usually in men, but sometimes women can present, especially in the setting of patients who have cervical cancer or any tumor in the pelvis. It can cause obstruction. So you have to always consider post-renal cause in men as well as women, and because it is something that can be easily corrected. All you need is sometimes a catheter to relieve the obstruction, and the kidney function will improve. So when you can't find from the history and from the examination and from investigation, namely an ultrasound, you can't find either a pre-renal cause or a post-renal cause, that is when you are thinking of renal causes of kidney disease, where the problem lies within the kidney. So what are the investigations? How do you manage an acute kidney injury? The first here is a situation where you have to first manage by two things. One is rise in creatinine from baseline and a drop in urine output. So those are the two things you really need to establish when you see somebody. So what are the complications? So why do we have to manage the patient first before we investigate? Because the complications of acute kidney injury can kill somebody. So acid-base and electrolyte disturbances are the most important, and most importantly, hyperkalemia and metabolic acidosis. So because the kidney is integrally involved in maintaining acid-base balance and in keeping the potassium under control. And the second thing that it is involved in is fluid imbalance. So if you have somebody who is dehydrated, you may need to give them fluids. On the other hand, more dangerous situation is where they're actually got lots of fluid on board, because the two things that the kidney does is get rid of toxins and get rid of fluid. So and these two things could be the indications for dialysis as well. And the other thing you need to identify is sometimes acute kidney injury is not an isolated phenomenon. It is a systemic process. Like you could have a vasculitis, which is affecting the lungs and the kidney at the same time. So what will kill the patient is not what affects the kidney, but what affects the lungs. For example, ANCA vasculitis, you have to actually, if the patient is coughing up blood, then you'll have to actually take them straight to the ICU and start plasma exchange. The other thing you have to think of is in the history, you may want to find out if they had drug toxicity, like lithium or gentamicin, or that they had a hemolytic uremic syndrome, whether they're septic, because these are the things you'll have to manage in addition to the acute kidney injuries. The acute kidney injury may be the manifestation of something more sinister. And then subsequently other things like anemia, hypercatabolism, malnutrition, reduced immunity. So these things come, but in the initial instance, it's the most important thing. If you ask for two things, one is acid-base electrolyte disturbance and volume status. So these are two things you really need to manage. Okay, so this is basically the once you establish the cause of once you establish the electrolyte disturbances and management of them, then does anyone have you do you have any have you had any lectures or any gone through anything about management of hyperpotassium and management of acidosis, or has it been part of any lecture or anything for you guys?
No, sir.
Okay. So do you know how to manage, what are the things that you need to manage? Suppose you'll finish final year now and you'll suddenly become an emergency doctor, you'll be in the emergency. So you'll be managing the accident emergency as part of your medicine rotation. So how do you manage someone who's come with a potassium of, let's say, 6 or 7? The things to do are, one is immediately the first things you need to do are give them insulin and dextrose, like 10 units of insulin in 100 or 200 mils of 5% dextrose. And what will do is the dextrose and the insulin will help in moving the potassium from the extracellular to the intracellular compartment. Second thing to do is correct acidosis, because all patients with acute kidney injury are acidotic. So you should give them intravenous bicarbonate to bring their bicarbonate levels up to at least the lower limit of normal. Then you have to give them calcium gluconate, because calcium gluconate stabilizes the cardiac membrane. Why do the patients with hyperkalemia die? Because they have cardiac arrhythmias. They die because of ventricular tachycardias. So the fourth thing you need to do is you can also do them salbutamol nebulizers, because salbutamol again helps in moving the potassium from the extracellular to the intracellular compartment. You're just moving shifting the potassium from the extracellular space to the intracellular space, so the potassium is not toxic. And in the long run, you have to give them powders called resonium powder, which kind of it's a potassium exchanging resin, and it will bind the potassium. Now, these things which I found useful when I was a medical student or when I was doing my MD was mainly as an intern, what I found useful was the Washington Manual. So in the Washington Manual or Oxford Handbook, you'll have descriptions of medical emergency. So the one emergency, if you have to learn from this lecture, one emergency you have to learn is management of hyperkalemia. So if you go back and learn that, I'll be very, very happy, because that is something that you can use to save somebody's life. Okay. So now that you have managed somebody's hyperkalemia and you manage the acidosis, you've given them bicarbonate, you've settled the potassium, you're happy that they are, if somebody is fluid overloaded, you can give them Lasix. Lasix is a diuretic. It's a fluid injection, so it helps them make lots of urine and try to get rid of the urine. They will be resistant, but at least you can try to excrete some fluid. And on the other hand, one is to get rid of the extra fluid, and the second thing is also reduce the intake. So it's a two-way process. So you don't give them too much fluid if they're fluid overloaded. If they're dehydrated, you give them fluid, but if they're too volume overloaded, you should give them diuretics and restrict fluid intake. So once you've taken care of the electrolyte problems and you've taken care of the fluid status, then you know that the patient will live, the patient will not die, and you've made all those life-saving measures. Now you need to find out what is the cause of kidney dysfunction. So the single most investigation in somebody with acute kidney injury is not a blood investigation, it's a urine investigation. Because the urine, if you see this, the shaded section shows urine sediment examination, because that will give you heaps of information. Because if your urine sediment does not show any red cells or white cells or any protein, then it means that there is nothing intrinsically wrong with the kidney. It is all pre-renal or post-renal. So that is an evidence. On the other hand, if your urine shows lots of red cells, you start thinking about conditions like vasculitis, like there is inflammation happening within the kidney. There are different conditions like ANCA vasculitis, lupus nephritis, especially in young women. So that is very important. So at your level as a final year student, what you do is you look at the urine sediment, you do the dipstick and say, okay, you call your senior register and say, the urine, this patient has got acute kidney injury. I did the urine shows lots of red cells and lots of protein. I think this person may be having some kind of vasculitis. So and they will take it up from there, and then they'll manage. So that urine sediment is the most important thing. If you ask for one test in the emergency, that is the most important. It's very easy to do. All you need to do is put a dipstick and look for blood and protein. And the other thing that we want to do is, which can be fixed correctly, is an ultrasound. The ultrasound will tell us if there is an obstruction. And again, management is very easy. All you need to do is put a catheter, and the bladder, once it's decompressed, the kidney starts functioning again. Now, I've mentioned about a renal biopsy here. The renal biopsy is something that will happen once you stabilize the patient. You've done all the tests, but there is something going on within the kidney, because you find that there is a urine which shows lots of red cells or white cells, and there is some inflammation going on, but you don't know what it is. So the biopsy will tell you, just like a liver biopsy, a kidney biopsy will tell you what is happening within but the biopsy results will take time to come back. It may take a day or 2 or 3 days, but based on your preliminary diagnosis, you should start treating the patient. And the biopsy doesn't happen straight away. The biopsy happens only after the patient is stabilized, and you know that the patient is safe to have a biopsy. So what clinical history you want in acute kidney injury? You have to ask for symptomatic history, which includes poor fluid excretion, resulting in fluid excess, reduced urine output, short. So when somebody is not passing much urine and they're collecting fluid, so they will start. So the symptomatic history is basically, are they short of breath? How is their breathing? Are they short of breath on lying down flat? Orthopnea, very typical cardiac history. Do they have paroxysmal nocturnal dyspnea? Because you can apply the same thing to renal and cardiac history. And do they have any swelling in their legs or swelling in their face? Now, the typical history you have in the post-streptococcal glomerular nephritis is facial puffiness. Children come with facial puffiness. So are they short of breath? Are they more short of breath and lying down flat? Are they passing less urine? Or do they have any swelling? So this will tell you about the fluid status. Now, about the toxins, what do the toxins do? How is their appetite? Are they feeling nauseous? Are they feeling tired? Do they have any palpitations due to the arrhythmias, which is very uncommon? And if the toxin accumulation has been going on very acutely over a short period of time, then they may become confused as well. So those are the things you ask for in the history. Now you want to ask for history to find out what caused the acute kidney injury. That's the etiological history. There you ask for fluid depletion. Did they have any vomiting, diarrhea, excessive sweating? Because sometimes people who run for long distances, they run marathons, and they don't drink enough water, or they're working in a very hot environment and they're not drinking enough water. So they can become dehydrated. Sometimes there are patients who are sick, but they don't stop their diuretics, which are the cardiac medications. They continue to take those medications, and then they become dry. So medication history and the fluid history is important. Drugs, you have a lot of medication, but the most common drugs that you have to ask for is, one is non-steroidal, like Voltaren or ibuprofen, Voltaren, all those non-steroidal medications. Anything apart from paracetamol can cause Voveran. I think the common drug they call is Voveran, and there is a combination of ibuprofen, paracetamol, which is also common in India, I think. So that medication is important, because sometimes people take this in large quantities, and that can cause kidney injury. Antibiotics can sometimes cause an allergic reaction. I've not seen it commonly in India, but in Australia we do see a fair few patients with that. Lithium is an important medication. Why is lithium important? Lithium is something that we use in bipolar disorder, and lithium can cause acute kidney toxicity. It can also cause chronic kidney disease as well. But lithium is a very important medication, because that is the only medication which has been shown to prevent suicide in patients with bipolar disorder. So you may not be able to stop lithium, but if the lithium levels are very high, we may want to stop it temporarily till the lithium levels come down. And kidney stone disease, very, very uncommon as a cause of acute kidney injury, unless it's bilateral or both sides. Again, clinical history, if you want to look for any any history to suggest any systemic process, you look for history suggestive vasculitis. Do they have any rash? Do they have any joint pains? Do they have Raynaud's phenomenon? This could point towards any systemic problems like Sjogren's syndrome or lupus nephritis, which is very common. Do they have any history of gout, which could tell us that they have got lots of high uric acid levels, which can sometimes cause kidney dysfunction, very rarely acute kidney injury. Prosthetic symptoms. What are the prosthetic symptoms? Urgency, hesitancy, poor strain. That means they're trying to pass urine, they're having difficulty passing urine. They want to pass, but it takes some time for them to start. And they also have urgency, which means that if they don't, um, if they are not able to reach the toilet in time, they may actually leak urine. And they can also have a feeling that once they pass urine and they come back, they want to go back again. So these are the symptoms of prosthetic enlargement in men. So why is a history of trauma or musculoskeletal injury important? Why is that important? Because, like, for example, somebody is involved in a building accident, or somebody's had a road traffic accident. They can have muscle damage, and with muscle damage you get rhabdomyolysis. So all the muscles, they break down, and they filter into the kidneys, and they can cause an acute kidney injury. So that history is very important. Especially you'll find this after earthquakes or a big building collapses. You'll find rhabdomyolysis. Myeloma is important because myeloma is a hematological condition, but myeloma can manifest with acute kidney injury. Any recent travel, especially, for example, if you travel to Kerala or during the rainy season, there is a high incidence of leptospirosis. It can cause liver injury and kidney injury. So that travel history is quite important. So these are the things that should go through your mind. I mean, any new medications, any travel, any diarrheal illness, or any accidents, and any other systemic features, any other system involved. Do you have any cardiac symptoms? Do you have any joint symptoms? So once you screen through all the symptoms, you'll come to, once your patient is stabilized, you take this history, you establish what is the cause of the kidney injury. Don't have to worry about this. So the management of acute kidney injury is, again, the same thing. You have to maintain fluid balance, because if they are fluid overloaded, you're looking at dialysis. And if they are dehydrated, you will not recover unless you give them enough fluid. The kidneys won't recover. And you also have to manage the electrolyte and acid-base disturbance that we discussed before. So we have to prevent dehydration and overhydration. So you need to watch. So the simple ways in which to assess fluid status is, one is the clinical assessment is the jugular venous pressure. So the jugular venous pressure, JVP assessment, is a basic thing for everybody. So if the jugular venous pressure is elevated, then you obviously back off. Don't give them more fluids. Then you listen to the lungs. You see if they have any crepitations in the bases of the lungs. And then you can check their weight every day. And then you look at look for sacral edema or ankle edema. So these are all the signs of fluid retention. The most sensitive assessment for fluid retention is weight. So the weight changes. The weight is a very sensitive way of looking at fluid retention. And I talked about insulin dextrose, calcium gluconate, resonium for hyperkalemia, bicarbonate supplement in severe acidosis. The nutritional support will come later on. It's not an emergent thing. Now, you've given all these things, right? You've given them bicarbonate, you've given them insulin dextrose, you've given them calcium gluconate, you've tried to stabilize everything, you've given them Lasix to get rid of the fluid, they're trying to make them pass more urine to optimize the fluid status. If all of these things fail, then the next option for you is dialysis, which is called as renal replacement therapy. You go for dialysis, hemodialysis. We'll discuss a little bit about dialysis in the end, because it's a slightly complex topic. You only need to know a little bit about dialysis because you have a lot of other subjects to learn as well. So the management should be tailored to the etiology. For example, if it's a vasculitis or an immune problem, you give them steroids. Glomerulonephritis is an immune problem, needs to be investigated and managed with immunosuppressants. That could be steroids, cyclophosphamide, cyclosporin, tacrolimus, a lot of medication that we can use. For example, if you have someone who's been using drugs or nephrotoxins, for example, if they've been using amphetamines, or if they've been abusing cocaine, or if they've been abusing non-steroidal agents, then you have to identify that, and that needs to be stopped immediately. And if there is an obstruction, we relieve that with a catheter, or if you can't put a catheter, then you need to do nephrostomy, which is putting a tube into the ureters. If it's pre-renal acute kidney injury, you give them lots of fluid. And if it's a cardiac failure or liver failure, you try to manage that, because without managing that, the kidney function won't recover. Now, what are the common causes that I find here is the drugs that I commonly find inside the hospital is gentamicin, because if we give them gentamicin regularly, within day 7, they will develop an acute kidney injury. So nowadays, we only give a single dose of gentamicin when somebody comes to the emergency, and then subsequently we try to give an alternative medication. Or if you have to give gentamicin, you have to strictly watch the levels very closely. And other medications are like Voltaren or Vovran or ibuprofen and medications like that. And antibiotics can sometimes cause an allergic reaction in the kidneys. Contrast nephropathy, everybody talks about contrast nephropathy. Somebody's got kidney disease, and if you give them contrast for CT scans or other things, then you can develop a contrast nephropathy. But it's probably, if you manage it very safely and if you give them enough fluids, contrast nephropathy is not a big issue. One thing to remember is, suppose you're a surgical trainee, you're in a surgical, you're doing a vascular surgery or in general surgery, you'll get patients who are sick, who got sepsis, who got bowel problems. One thing to remember is after every surgery, especially after cardiac surgery or any other surgery, all these patients run the risk of developing an acute kidney injury as well, because during the intraoperative procedure, their blood pressure will fluctuate significantly, their fluid status will fluctuate significantly, and they may also get medications like the non-steroidal agents for pain management. So a combination of all this can cause kidney dysfunction. So that is something to remember in patients who are coming out of surgery, especially older patients. So this is just you have different apps for calculating risk. So this is just one of those apps to calculate the risk of contrast nephropathy. So how do you prevent it? You identify high-risk patients, patients who are septic, patients who are older, patients who have diabetes. They're all high-risk patients. You manage them, manage the fluid management, do fluid management in peri-procedure, avoidance of nephrotoxins, regular monitoring of renal function, regular monitoring of nephrotoxic drug levels. And this is especially for in the setting of patients who are going for any surgery. Now I'll talk a little bit about chronic kidney disease. Now, what is chronic kidney disease? What's the definition of chronic kidney disease? So the chronic kidney disease basically is somebody whose kidney function has remained low for a period of around 3 to 6 months. So you've seen them come to the clinic, their creatinine is 2.5, and you looked at all the acute causes, you tried to do investigations, you can't find anything, and you manage the diabetes and blood pressure, and 3 months later you check the kidney function again, it's still 2.5 or 2.6, which means the kidney function hasn't really improved or changed, and it's remained stable at a lower level. So that is the definition of chronic kidney disease. So chronic kidney disease is defined as patients who have kidney dysfunction which is remained stable over a period of 3 to 6 months without any improvement. It's called as chronic kidney disease. Now, 30% of patients have chronic kidney disease purely due to diabetes. So diabetes, you can look at microvascular complications like eye disease, nerve damage, and kidney disease is very common. So 30% of patients with diabetes have kidney disease. If you look at patients with kidney disease, 30% is due to diabetes. Another 20% have kidney disease due to hypertension. So if you combine both, you have around approximately 50% of patients have kidney disease because of diabetes and hypertension. So it is by far the most common cause of chronic kidney disease all over the world. Now, other causes include, glomerulonephritis. In the past, they've had some episode of acute kidney injury from which they have not recovered completely. Patients with bipolar disorder who take lithium, patients with arthritis who take non-steroidal agents for the pain management. Then other condition to remember is reflex nephropathy. Reflex nephropathy is a condition where the children are born with where the urine leaks back from the bladder back into the kidneys because of a defective valve where the ureter inserts into the bladder. So it is becoming less common now because nowadays our ultrasound technology has developed so much that this can be picked up when the baby is in utero and it can be managed. So nowadays we don't see this. So if you find somebody with reflex nephropathy, it'll probably be someone who's older, in their 40s or 30s or 40s. Now, in the younger population, you will not find this condition. And the other most important thing you should remember is kidney disease can run in families, especially there's a condition called autosomal dominant polycystic kidney disease. So it is as the name describes, as a dominant condition. So you have if one of your parents has got it, then there is a 50% chance that you will get it. and there's a 50% chance that you'll give it to one of your children as well. So in history and investigations in chronic kidney disease, you look at, most importantly, look for history of diabetes, look for history of high blood pressure. When you look for diabetes and high blood pressure, the most important thing is how well is the diabetes controlled? How well is the blood pressure controlled? Because patients who have diabetes which is very well controlled seldom progress to kidney disease, and patients who have blood pressure well controlled again seldom progress to kidney disease. Patients who have poorly controlled diabetes or high blood pressure progress to kidney disease. And diabetes is not a difficult disease to manage now. Some top athletes have diabetes, like Wasim Akram has type 1 diabetes. Some of the rugby players have type 1 diabetes, so they can manage it very well. So it depends on how disciplined you are. And history of any medication, as we discussed, the same thing in acute kidney injury. Here again, you ask for history of medication. Have you been taking any medications? Especially medications which can cause allergic reactions over a long period of time, or the proton pump inhibitors like pantoprazole, omeprazole. These drugs can do that. Have they had, so they could, to get a history of reflux nephropathy, the two things you ask for are, have you had any severe urine infections as a child, or have you had any bedwetting? So bedwetting up to the age of 4 years is normal, but any bedwetting after the age of 4 years is abnormal. So if they give you that history, then you think that they may have reflux nephropathy, and an ultrasound will give you the idea, because it will show scarring of the kidneys, and will also show very dilated ureters as well. And one thing to remember is, if somebody has reflux nephropathy, there's only a 50% chance that they would remember the symptoms. 50% of the patients may not have had symptoms. Men, you ask for prosthetic symptoms. I've already described that. Frequency, incomplete emptying, nocturia. Family history is very important. If you say that, yes, my father or mother had kidney disease, my grandfather or grandmother had kidney disease, then you start thinking of genetic conditions, especially polycystic kidney disease. And in terms of investigation, the most important thing again is the urine. The urine is extremely important. So urine protein, urine microscopy. You're looking for red cells, white cells, and casts. Casts are nothing but they usually, everybody's urine has got some casts. Casts are just protein collections, which everybody's kidney secretes. But when you have red cells and white cells which are stuck on the cast, you know that there's a bleeding happening within the filter, within the nephrons. So that is the evidence that it is not coming from either the bladder or ureter or from a stone or anything. It is actually microbleed happening from the nephrons. So that is why red cell cast or white cell cast are quite important. And again, ultrasound imaging is very important. So these are the basic investigations: urine investigations, imaging, and then subsequently all the blood investigations to look for other causes. So we identify and manage risk factors. For example, manage diabetes and blood pressure very well. Specific treatment for specific issues. So if you have a prostate enlargement, they need to have a prostate surgery. And unfortunately, some patients, we can't help them. They can progress. So you start preparing them for dialysis. Or alternatively, you can work them up for transplant. In India, transplant is probably more popular than dialysis because of the cost reasons. The transplant is more cost effective than dialysis. Even here, transplant is more cost effective than dialysis, but there is no, the organ availability is an issue. So I'll just briefly touch on electrolyte and acid-base imbalance. The most important imbalances that you need to know about are hyponatremia and hypernatremia. One thing to remember about hyponatremia and hypernatremia is that it is not excess sodium or low sodium. It's actually a problem with the water balance. So if you have excess water, you develop hyponatremia. If you have less water, you develop hypernatremia. So it's more to do with your sodium and water balance than the total sodium content. Similarly, hyperkalemia and hypokalemia again exist in the context of a kidney injury. Acidosis and alkalosis is again a big topic. First thing to remember is the basic approach to anybody with acidosis or alkalosis is to identify if it's a respiratory or a metabolic cause for alkalosis or acidosis. So once you identify it's a respiratory cause, you manage that accordingly. If it's a metabolic cause, you manage it accordingly. So I won't delve into too much detail in this because at your level, as long as you identify that the pH. So when you say the normal pH is between 7.35 and arterial pH is between 7.35 and 7.45. But anything less than 7.35 is acidosis. Anything more than 7.45 is alkalosis. Okay. So it's very complex, and each session will each issue will need a session by itself. But I think I'm doing one session at the end of the year where I'm going to focus on the electrolyte disturbance, one of the electrolyte disturbances. Now, briefly about dialysis. So dialysis is something you do when you've tried everything to manage patients with acute kidney injury or patients with chronic kidney disease have progressed. So you have to have that. There are two modalities of dialysis. One is hemodialysis, the other is peritoneal dialysis. Hemodialysis, as the name implies, is where you have a method of extracting blood from the patient, and you clean it through a hemodialysis machine, and if you filter that and you send and you are able to reinfuse the patient. So how do you take blood out? There are different types of access. One is a catheter. The dialysis access is a catheter, and the catheter will have two lumens. One lumen will take the flow will be from the patient into the machine, and the second catheter will be the flow back from the machine into the patient. Now, why is catheter ineffective or less optimal way? Because catheters are associated with infection. Anytime any patient has got any plastic cannulas or catheters, it's a source of infection. So the best option is to have for them to have an arteriovenous fistula, where you unite a vein and an artery together, and you let it develop over a period of 6 weeks, where the vein gets arterialized because of the high pressure. And that is the chance of having an infection with the catheter is 7 times the risk of having an infection with an arteriovenous fistula. So that is why an arteriovenous fistula is always preferred for long-term hemodialysis. The dialysis modality. So hemodialysis are different modalities. One is in the common outpatient setting, you have intermittent dialysis. So the patient will come 3 times a week to the dialysis center, get dialysis for over a period of 4.5 to 5 hours, and they'll go back home. In the ICU setting, when they're very sick, you use continuous veno-venous hemodiafiltration, where the machine runs for over a period of 24 or 48 hours, and it continuously doesn't stop, because that's a more gentler form of dialysis. I think for dialysis, from dialysis perspective, you know so much, it's enough. The peritoneal dialysis is where a catheter goes into the abdomen, and there is a fluid exchange. So there is a fluid that goes in, which is a fluid is basically a dextrose-based solution, and it'll suck up all the toxins, and then after a few hours, the patient will drain the fluid out. Now, it can be done 2 ways. One, a machine can do it, which is known as automated peritoneal dialysis. And the continuous ambulatory peritoneal dialysis is where the patient themselves do the dialysis. Like they'll do exchanges every 6 hours. So every 6 hours, they'll empty that abdomen and fill new fluid in. Okay, so I think that brings us to the end of this introduction. There's a lot of things, but the basic things to remember are acute kidney injury, how to manage acute kidney injury, and how to investigate, especially the things to look for, or you need to do an ECG to look for investigate. You can do the ECG to look for any cardiac arrhythmias, and do the vitals, the observations, and then do the investigations and manage the patient before you go for further history. Now, I'll open the forum for any questions. You may have specific questions. I'm happy to answer them.
Okay, sir. Rahul,
Yes, Vinay, yes.
enable chat.
Oh, chat isn't enabled. 1 minute. Chat is enabled.
Yeah, okay.
Is there a chat? I'll see if I can see the chat.
Sir, we just
Yes.
enabled. Students will ask questions.
Okay, let's go to this. And, stop share. And chat. Okay, now I can see your chats if you have any. Resonium. Okay. So do you want me to talk through it or do you want me to type? I'll talk. Resonim is nothing but it's a resin. So it is a resin. What it does is it is like a powder in the form of a powder. So what it does is it will absorb the potassium, and it's an exchange resin. So it'll absorb the potassium in exchange for another ion. So it'll kind of it's a long-term solution for patients with hypertension. For example, if you give them insulin dextrose, it'll work for over a period of half an hour or 1 hour or a couple of hours, and afterwards the potassium will come back again. But resonium works over a period of a few hours, and it'll keep the potassium under control for a longer period of time. So it is spelled as RESO, spelled as RESONIUM. Yeah. Now we are getting newer agents as well, but this is something that practically right now at this point in time, this is what we have. So we have a few patients who are on long-term resonance, like they take 15 grams of resonance every day to keep the potassium under control. Okay, so AV fistula for dialysis is basically, so you have you can connect your radial artery to your cephalic vein. I don't know if you remember in anatomy, that's in the forearm, or you can connect the brachial artery to the brachial vein. So basically, you can form a fistula in the forearm or the arm. So basically what you're doing is arterial system is a high pressure system, whereas a venous system is a low pressure system. So when you connect an artery to a vein, what happens is the high pressure is transmitted from the artery to the vein. So the vein starts becoming bigger and bigger and bigger, and over a period of for 4 to 6 weeks it becomes quite big. Why do we need a fistula? Because for dialysis you need large flow volume. So if you look at the dialysis machine, if you walk past the dialysis machine, you'll see there'll be flow of like 500 mils a minute. So if you have to be able to extract 500 mils of blood from the patient in a minute, you do need to have a large vein. You can't use a small bore vein. So the needles you'll see are large needles. So just to make the flow better, and to make the access better, that is why the AV fistula is created. So the AV fistulas are created by the vascular surgeons, and that helps in dialysis. So if you see long-term dialysis patients, hemodialysis patients in any dialysis center, you'll find that many of them have a fistula in their arms. A fistula is an abnormal connection in short. So in terms of the Anirudh's question is Akin or rifle, it doesn't really matter. So there are three classifications: Akin, rifle, KDIGO. So if you drill down and look at all of them, they are all the same. So what what you need to see is, if a patient comes in and they say the creatinine is 2.0, and you say, okay, what was the result last month? If he says no, the result last month was normal, I did a routine blood test, it is only 1.0. So it means that the creatinine has gone up, and they're making less urine. So Akin rifle was designed more for the intensive care setting, whereas Akin is from the acute kidney injury network, and practically it doesn't make any difference. So I would say that you can apply both, and you don't really have to know the stages, but what is more important is how rapidly is the urine output coming down, and how rapidly is the creatinine rising. So that is probably the most important thing. Either it's Akin or rifle or KDIGO, doesn't matter. So the next question you have is, what are all the cases of renal transplant is considered superior than? Yes, renal transplant is considered superior than dialysis because the mortality on dialysis is very high. So if you look at patients, if you follow the patients long term, there is a high incidence. The mortality is close to 10% per year. That means you'll probably lose 10% of your. There's a 10% chance of dying every year on dialysis. That's a very, very big number. In fact, there are studies which show that people who are on dialysis for more than 5 or 6 years, their mortality is much higher than having colon cancer. So that means your mortality for a patient on dialysis is worse than for a patient with cancer. So that's a very high mortality. On the other hand, patients who have a transplant, the mortality is far less. So transplant is not a complete cure. It's again, it is a solution where you call renal replacement, where you get somebody else's kidney. but the mortality on a transplant is far less than someone who's on dialysis. And moreover, the next thing you look at is cost. So to dialyze somebody 3 times a week, for example, average cost would be like 2,500 or even 3,000 rupees per session. It's 9,000 rupees. But if you look at somebody on transplant, that is 9,000 rupees per week, 9/4 or 36,000 per month. And then you're looking at a year's expense. But on the other hand, transplant medications are probably cheaper. So in the long run, it is far cheaper and better to maintain somebody who has a transplant than somebody who has a dialysis. So biopsy is done usually. Next question is the biopsy. Biopsy is done usually and by the nephrologist under local anesthetic, and it is done under ultrasound guidance. So just like a liver biopsy, we look at the ultrasound and we do real time. That means we can actually see the kidney moving up and down. We ask them to hold their breath and then we do a biopsy. So what may, in one question from Anjali is what way is the management of each stage of kidney injury differ? The management of each stage of kidney injury, in the sense that if somebody's got very severe kidney injury, then you're probably going to manage their complications are much higher. So they are far more sicker. So you'll probably be looking at you'll probably think that the event that made the kidney injury worse is much worse. For example, the sepsis is very severe sepsis. If they have a vasculitis, it is very severe vasculitis. So they need more acute management. On the other hand, patients with a milder form of acute kidney injury, you can sometimes manage them as an outpatient. For example, if they come to you and say that, oh, I found that my kidney function has dropped a little bit in the last 1 week or 2 weeks, and I did a test and I found that. So you could probably identify the factors. You don't need to admit them, and you can manage them as an outpatient. So the severity depends on, like in any other condition, it depends on how severe the condition is and how acutely you need to manage them. How do you prevent, next question from another is how to prevent intensive care acute AKI. So the thing about, it's not, I wouldn't say the AKI is acquired in the ICU. The thing is, when somebody goes to the ICU, it means that they are very sick. So the acute kidney injury is probably just part of their severe illness. Sometimes in the intensive care unit, they have to have different medications which are life-saving, and some of the medications, especially for example, if you have some cancer treatment medications that they are on, or if they are on antibiotics, then they may develop an acute kidney injury as a reaction to that. So, but by and large, someone develops acute kidney injury in ICU, it is not because of their management, it is because of their initial condition and the cause and the disease because of which they presented to the ICU. Okay, so more questions coming up. AKI due to drugs, reversible, definitely. So the three drugs that you want to remember is, one is non-steroidal agents like Nurofen, Voltaren, ibuprofen. In India, I think the most common ones are Voltaren and ibuprofen. And one thing to do is stop the medication. Sometimes we need to give them steroids to help in reducing the inflammation. And sometimes they may need a biopsy to confirm that. So the other set of medications are antibiotics like penicillin antibiotics, amoxicillin, ampicillin. They can sometimes cause a reaction. The third set of medications are all these proton pump inhibitors like omeprazole, esomeprazole, and pantoprazole. Those are the ones. So these are the three classes of medication which can cause kidney injury, and they are all reversible. Yes, they are all reversible. Gentamicin-induced drug toxicity is reversible. In most cases, almost 90% of cases, they're reversible. Okay, why is the next question is why is a transplanted kidney in the place in the iliac? The transplanted kidney is placed in the iliac fossa because you need to be able to connect three structures to the of the transplant kidney. One is the ureter, the second is the renal artery, the third is the renal vein. So for surgical reasons, it is easier to place them in the anterior abdominal wall and in the anterior abdomen in the iliac fossa, because they are all connected to the iliac artery and the iliac vein. And sometimes when you get a cadaveric kidney, you may get a right kidney or a left kidney. So depending on which kidney you get, if you get a left kidney, it is great because you have a longer ureter and a longer artery and a longer vein, and you place them in the right iliac fossa. So that is mainly for that reason rather than anything else. And when you do a transplant, you do not take the old kidneys out. The old kidneys stay in the same location unless there is any specific reason to remove the kidney, like cancer or anything. Now, do we remove the AV fistula after dialysis? No, we do not, because the AV fistula is a long-term thing. So the AV fistula is created, and once they're used for dialysis, so the nurses will place the needles in the AV fistula and take blood out, and so there is an arterial needle, there's a venous needle. So in a fistula, the needles go in two different locations, and the fistula stays. The fistula is not removed. So the fistula is a permanent feature of the person. So they'll walk around with the fistula, because the fistula is it takes around 6 weeks to form, and it is not removed. Previously, they used to make small connections for urgent dialysis between the artery and the vein using graft, but nowadays we don't do that. We have a fistula which is not removed. The fistula is a long-term fixture. Okay. So Rahul and Fida, is everything all good? If you have any further questions, you can always um, compile that and put it on a Microsoft Word document or something, and attach to the WhatsApp, so I can see and I can answer those questions.
Yes, sir. Yes, sir. Sure.
Okay. It's all good?
Yes, sir. Yes, sir. I
Okay,
think no one is out.
Okay. So the video was clear, the audio was clear, and you could see all the slides and everything. So it's all good. Okay.
Yes, sir.
Thank you, sir.
Okay. All right. So we'll
Thank you so
hang
much.
up now.
Thank you so much.
Thank you so much.
Yes, sir. We can
Yes,
end
sir.
this.
No worries. All the best. Okay. I'll leave the
Thank you,
meeting
sir.
now. All the best.
Yes, sir.
Thank
Thank
you.
you so much.
Thank you.
Thank you.
Thank you.
Yes, sir.